Good evening, everybody, and welcome to Prostate Forum. We are a nearly 40-year-old prostate cancer support and information group here in Orange County, California, but we serve really all of Southern California, and some of our friends come as far away as New Jersey. We are honored tonight to have Dr. Joseph Pinzone, MD, Chief Medical Officer of the Hyperthermia Cancer Institute. Now, I may have misled you folks into believing the doctor is going to talk about hypothermia, but we're going to talk about cancer and heat tonight rather than freezing. A little bit about the doctor. He is the Chief Medical Officer at the Hyperthermia Cancer Institute here in Irvine, California, in Orange County. He has secured grants to study other tumors besides just PCA, including pituitary and breast cancer. He has held faculty positions at George Washington University, Ohio State College of Medicine, and he was assistant professor of clinical medicine at David Geffen School of Medicine, UCLA. Give a big warm welcome to Dr. Pinzone.
Well, thank you very much for the kind introduction. I'm happy to be with everybody today. Thank you very much for attending. Let me just introduce my organization, which is Hyperthermia Cancer Institute, and we're in the Hoag Hospital, outpatient hospital building in Sand Canyon, 16300 Sand Canyon in Irvine. We've been there for almost a year. And we previously had an office in Santa Monica. So I've been personally doing this, July will make 7 years. And just to clarify with everybody, as Mr. Burke had mentioned, I am not an oncologist. I'm not a urologist. I'm not a surgeon. And I'm not a radiation oncologist. I'm an endocrinologist by training. So the same way many of you may have seen a urologist as an initial quarterback or maybe a long-term quarterback for your particular issues, I'm the quarterback for the majority of people with endocrine cancers, thyroid cancer being the most common one. Of course, we work in teams. There's surgeons, there's radiation oncologists. There are on occasion oncologists, just the same as with prostate cancer. It's actually a pretty similar type of a relationship. So I just wanted to clarify that. I do have a lot of experience in tumor biology, and I wanted to give you an introduction to hyperthermia because, we are actually an FDA-approved therapy. And not a lot of people know about hyperthermia. And I'll tell you, there were reports back from the times of the Egyptians of using heat on cancer. I think the more recent phenomena, just to give people a sense, is really started when people got smallpox and they got febrile for maybe 3 weeks to 105. A lot of times a tumor that you could palpate, let's say a breast cancer or something like that, it was noted that it would often diminish in size, completely go away. Sometimes that was permanent, sometimes that was temporary. And a doctor by the name of William Coley in New York decided to really take it to another level. There's still the William B. Coley Award, and very prominent immunobiologists who are typically physicians will often win that award because he really created the first tumor vaccine. So what he noted was a young girl with sarcoma, a different type of cancer, of course, who had an infection with streptococcus called erysipelas, actually had her tumor shrink. So it was a little bit of the Wild West, even though he was from New York. We'll call it the Wild West in quotation marks. And so he began injecting streptococcus that causes the erysipelas condition, streptococcus bacteria, directly into tumors. Eventually, fortunately, he heat killed that bacteria, he combined it with another heat killed bacteria, and he would get 50% durable response rates of not only the tumor he injected, but abscopal, from the Latin away from the scope. A lot of the metastases would shrink. And in 1936, when he passed, the field never really got revived until really the 80s. So our technology, which uses ultrasound, I'll get into that in a moment, has been FDA approved since 1987. And in fact, Medicare will pay for you to get hyperthermia. A little bit of a quirk in that it will only pay for it if combined with radiation and not with chemotherapy. And that negotiation of how that occurred was before my time, so I don't fully understand exactly why. The reason I bring that up is because other insurers, however, do cover with chemotherapy or with radiation therapy. And so we're designed to make those therapies work better. All will become clear when I actually start the presentation. But I wanted to give you that background because, even though many oncologists, many urologists, many surgeons and radiation oncologists don't know about hyperthermia, there's one other technology, and it uses microwaves, and it's also FDA approved in the United States. And so it really is worth knowing about, because there really is no adverse effects on normal cells, because as you'll see with the temperatures that I'm going to show you, we don't burn anything. We just heat to change the physiology of the cells. So I'm going to give you all the same presentation, a slightly modified version that I give to everybody. And I go ahead and explain to patients the mechanism of action the same way I do to my colleagues. Again, maybe in a slightly different way, but not dramatically. It's not that complicated. So with that, let me show you the machine that we use. And, we have one center in Irvine. Again, we used to be in Santa Monica, moved down to Irvine. And as you can see, this machine is quite dated. And we're in the process of fabricating new machines because we want to expand our operation to other facilities. But before getting ahead of ourselves, this is called the Sonotherm 1000. And if you look at what's happening to this particular patient, we're treating her neck, right? So let's pretend we're treating a head and neck cancer. The FDA approval that we have is for all solid tumors in combination with chemotherapy or with radiation. So we're not instead of, we're with, for the reasons that I'm about to show you. So just to explain the machine for a moment, the little reddish numbers that you can't really see the numbers, but they're on that little piece that's on top. That's the thermal probes that we use to measure the temperature at the skin. We don't put them into your body, nothing like that. And then what's contacting her neck, which in our facility contacts some plastic, then some gel under it, is a silicone-based water bolus with cooled water in it. And up near where the hose connects, up in that part of the head up there, is a crystal. And the crystal creates ultrasound waves. Now, those ultrasound waves are the same or the same type of wave as you'd get for a diagnostic ultrasound. And in fact, you can think of what we can treat as anywhere you can get a diagnostic ultrasound, we can use our ultrasound machine to treat, because the only difference is we're at a different frequency. So instead of bouncing off and, catching a picture, which is what a diagnostic ultrasound is, we go ahead and penetrate and heat to 106 to 109 degrees. So just Fahrenheit, just above a fever temperature. And we could heat up to 10 centimeters. And that's not including the subcutaneous fat. So pretty deep, between 3 and 4 inches. And for most tumors, that's plenty deep, especially when we're heating prostate, because we heat right at the perineum between the scrotum and the anus, that area that's right there where, many times an operation is done. Well, we do heating right there, and when you're kind of in a frog leg position, your prostate's right there. So it's very, very effective at heating many, many areas. The only areas we can't treat are the middle of the lung, because when ultrasound hits air, it stops, and we can't treat inside the head. But we can treat in the abdomen, we can treat breast, prostate. We're FDA approved for all solid tumors. And so when I present the data, and I'm going to present you actual medical data, okay, from studies, as you'll see, the data is more robust with certain cancer types. And the reason for that is, once you achieve an FDA approval, especially when you're a device like we are, right? For example, you wouldn't use the same chemotherapy on all different cancers. There's different chemos because they're very specific molecules for very specific tumor types. Machines are different. When you undergo radiation, external beam radiation, there's variations in techniques, but it's essentially the same radiation as was done decades ago. And so the machine is approved for many different tumor types, because like our machine, it does the same darn thing no matter what you're treating. So what goal are you trying to accomplish? Well, we're trying to do 3 different things, okay? So now that I've introduced you to the machine, let me show you that our sweet spot is right in here. Now people can see my cursor, is that right? Because I'm showing my screen. Okay. So 41 to 43, right in here's the sweet spot. And the sweet spot to do what exactly? 3 different things. Okay. So I'm going to continue on, and I'm going to show you the way that we help both chemotherapy and radiation therapy. So this is going to be mechanism 1. Mechanism 1 out of 3 leverages the fact that there's a normal blood vessel on, you're looking at the screen, on your left is a normal blood vessel. And you could see a very disheveled, if you will, poorly formed blood vessel on the right. And the reason why they don't form well is because cancers are by definition abnormal. So they don't really form, they form tumors, which they're not organs, they're not organized. And consequently, what can be an Achilles heel is sometimes exploited by all the mutations that are happening in the cancer. So in the center of the tumor, a lot of the blood vessels will collapse just from the pressure around it. And that's true of the vast majority, if not all, solid tumors. And when they collapse, a lot of times the center of the tumor will die off. And that's potentially a good thing. The problem is that those tumor cells, even though each individual one might have an Achilles heel, it might actually, because it's abnormal, it might even be extra sensitive to being able to be killed easily. But there are so many different mutations going on in the different cells that all of a sudden you need one to be able to live at a low oxygen environment, and the center of that tumor fills right back up with cells that now, because the blood vessels are not formed and they're collapsed, chemotherapy can't access them very well, and radiation can't work as well. Okay, people are not really often in the know about how radiation works, but I'm going to explain that. The chemotherapy is obvious. Okay, you can't get there if you can't, it travels through blood. When we heat a tumor, any tumor, we increase the amount of blood flow to that tumor. And you might think to yourself, gosh, aren't you feeding the tumor? In theory, yes, but that's why we're doing it with chemo or with radiation, because we're not really feeding the tumor. We're actually getting blood flow going at the center of the tumor so that the chemo can be delivered. And in the case of radiation, you're getting some cell killing while you're on the table, for sure. But you'll notice of those in the audience who may have had radiation, typically, and I don't know, your experience may be different, but typically you're not put directly into a scanner. Let's see how we did. It's often after about a month or so, or even more sometimes, that the scan is obtained to say, so how did we do on that radiation series of treatments? And the reason why that happens is because the way radiation works, a major way, is it takes oxygen and it creates what's called free oxygen radicals. And it uses those free oxygen radicals to damage the DNA of the tumors. So the cells are still alive, but when they go to divide, that's when they go into apoptosis, which is programmed cell death. And every cell divides at a bit different tempo. So cells don't divide every single day. It may take weeks for all those cells to go through that cell cycle. And that dovetails right into mechanism number 2. Okay. So everybody clear on mechanism number 1? Again, I know we're not at the question stage now, but just note, if you're not, feel free to ask a question about that. Okay. So now what we can see is that when the oxygen concentration goes low, the radiotherapy and chemotherapy effectiveness goes low along with it. Now with hyperthermia treatment, we can bring that oxygen tension up and improve the amount of oxygen that's available to damage the DNA. We want the tumor DNA damaged. That's how those cells are killed, by radiation, okay? A major way. So now mechanism 2, okay? Every cell in our body has the ability to repair itself. If it did not, we would all get cancer in the first week that we were alive, because DNA, the millions of base pairs, do not replicate with perfect fidelity. And so you can see there's a little radiation zap, and then there's a repair enzyme, and it gets repaired, right? So every repair enzyme works like other enzymes. pH matters and temperature matters. So when we heat the tumor, whatever that tumor is, prostate cancer or breast cancer or any solid tumor, we are now slowing down the repair of the DNA. So you're, again, in a race against time. When that radiation, during the radiation, the cells will try to repair themselves. And for a period after the radiation, the cells will try to repair their DNA. You don't want it repaired. You want it damaged so that when the cell goes to divide, it can't. Mechanism 2 of 3. Okay? Now mechanism 3 of 3. Okay? So when you have a portion of your body, or your whole body for that matter, that is heated to a temperature that's near or about where a fever is, your tissue reacts like it's febrile. Okay? So what happens? Well, heated tumor cells will cause the secretion of heat shock proteins, okay? HSPs, heat shock proteins. Now, the immune system, in order to not destroy your whole body, is very, very specific for certain types of killing, right? Bacteria, viruses, and in fact, tumors. The immune system surveillance is very important for us not to get big tumors throughout our lives. Unfortunately, it can't keep up. And with time, you accrue more mutations with age and you get cancer as cancer goes up as people get older. So in this situation, you can see these heat shock proteins stimulating the APC, the antigen presenting cells, that can now take a mutated protein that was previously inside of your prostate, and it can show it to the natural killer cells and the CD8 cells, which are a type of killer T cell. And those cells can then go and attack the tumor. Okay, so that is mechanism 3. Okay, so this is just a more advanced explanation of how that occurs, right? So now you've got those primed natural killer cells, those primed killer T cells, and they go ahead and they bind to the tumor cell, and they can now kill the tumor cell. Okay, now none of those 3 mechanisms are perfect by a long shot. Okay, but they do help quite a lot. And so we're going to get into some of the data that shows us how much they can really help. Okay, so when I go through the data, we're going to go through it. I'm going to show you charts that are very, very verbose. They're taken from studies. The studies are cited. You can look up the papers if you like. And so this is the first of them. Okay, so here, hyperthermia it was being used to treat localized prostate cancer, poor prognosis prostate cancer, locally advanced, hormone refractory or recurrent, and then biochemical relapse after prostatectomy. Okay, now let me just tell you, the strongest data that we have as hyperthermia itself comes in head and neck cancer, breast cancer, and rectal cancer. And one of the reasons why that's true is because we got a broad indication in 87. Again, I was long before my time. Broad indication. So there's not a lot of research that's done after you get that FDA indication. And because we had very similar rates of complete responses, meaning the tumor goes completely away. And we'll show that. I'm going to show that in another slide, okay? But because we had that in a number of different tumor types, the FDA did not require us to show that in every single tumor type. So for example, in appendiceal cancer, cancer of the appendix, pretty unusual tumor. We've treated multiple of them, but they're not common like breast cancer, colon cancer, prostate cancer. We don't have a study in those, that I'm aware of. But you'll see here many, many different studies. Now, let me tell you up front, these studies are not the strongest data. And this is taken from a review article that was, published in 2022. And it really talks about how these studies were done. And I'm going to show you studies that were done in a better scientific fashion than these studies. Because as you can see, these were single-arm studies. And normally what you want to do is, rather than just add hyperthermia to radiation, which definitely will give you some information, but it's not the gold standard, you want to split the group. You want to randomize those folks. And I'm going to show you studies where that's occurring. Again, it's not in prostate cancer, but you want to randomize those to radiation and then radiation plus hyperthermia. Chemo plus hyperthermia. That's not really available in prostate cancer, but that's okay. It's available in other cancers. And we are FDA approved in prostate cancer. And furthermore, if you read this study, what it shows you is that when hyperthermia is combined with radiation, okay, so here's the radiation type, here's the hyperthermia type that's used. What you really get are disease-free survival, local control, the overall survival, okay, and then the distant metastases-free survival, okay? So you've got all different ways to look at, so how did we do, okay? And you can see that these numbers, when they look at, either local control or overall survival are pretty darn good numbers for, localized prostate cancer. And then when you look at poor prognosis cancer, of course, they're not quite as good, but still not so bad. And when you're looking at overall survival, they're pretty darn good. And so when the doctors that did these studies compare them to legacy studies, you can say to yourself, they're looking a bit better. Again, I don't want to overstate the conclusions to be drawn from single-arm studies, but this is what we have to deal with. And life is not perfect, medicine's not perfect, and I'm not going to present to you something that's not accurate. This is accurate. We got some really good numbers here. We don't know exactly what they would be compared to radiation alone. We just know that they seem to be a bit better than radiation alone in the times when those studies were done. So again, we'll leave it there. And we're not going to all necessarily be up to speed on all of these studies and the exact numbers, but they look good. Okay, fair enough. This was really an interesting one. So there is such a thing as whole body hyperthermia, not in this country. This was done in Iran. Okay. So in Iran, they actually did radiation therapy compared to radiation therapy and whole body hyperthermia. Now, this is not a safe procedure in the ways it was told to me. I've seen people who've gone to other countries and they've talked about having seizures and things. I thought it was an interesting study. It was one of those ones out there. This is where men who had this is one of those ones where they did radiation alone compared to radiation and whole body hyperthermia. And they looked specifically at pain in patients who had multiple bone metastases. So this is pain relief in percentage. And you can see with radiation, which is often done to painful bone tumors to decrease the pain, you got some relief. Went from 10 to, 20%. Really quite dramatic with the whole body hyperthermia. There's not much to be drawn from this either. Again, I don't mean to be a naysayer of the actual modality I'm talking to you about, but I'm a realist. Okay. It's interesting. It's fascinating. We don't have whole body hyperthermia in this country, but I will tell you this, although we really are not indicated for improving pain, we have had probably approximately, we haven't looked at this carefully, but probably half the people who have pain, let's say in a spinal metastasis, will tell us within 1 to 5 treatments, hey, that got a lot better, or hip pain or something like that, bone pain with hyperthermia. So again, there may be something to this. It's hard to know for sure. I think what's better is to start to look at the studies where you see that they were prospectively randomized. They were multi-center studies. And now you can see the results of just the radiation therapy with radiation and hyperthermia. These are in head and neck cancers. This is in rectal cancer. And, you can see sometimes very, very big differences, sometimes not so big differences. It depends on the study. You can see this one study in head and neck cancer, there was a 0% overall survival in radiation therapy and a 53% overall survival at 5 years when hyperthermia was added. Now, that's one study. Again, head and neck cancer. We're in a prostate cancer talk, but this is the best data that we have to look at. So this is the one I'm showing you. And I'm not expecting everybody to go through all this stuff, nor am I expecting anybody to go through it with chemotherapy. Okay. But this is what doctors have to read. So let's break it down to some simpler charts. So this is what we have on our website. So for example, we'll extract some data from one or another study. And in breast cancer, what you see is in terms of complete response rate, meaning the tumor's completely gone, okay, goes from 41% to about 59%. Again, we're picking studies. Some of the studies are negative, and meaning they didn't show any effect. Most of the studies did show an effect, and that effect ranges, but you can kind of get a feel, it's about 40 to 60% increase, okay, in complete response rate. So let's use 50% for the sake of argument, right? That means that we are highly dependent on the underlying therapy. So if you get a really good result, it's your underlying therapy that gets most of the credit. It's the radiation, it's the chemo. But if the radiation and chemo don't work so well and you only have a 10% chance of getting a complete response, I can get that to 15. If you have a 50% chance of getting that completely gone, now I can go to 75% by adding hyperthermia. So again, we're a boost, okay? And there are certain situations where we know we work, okay? And those are, I'll tell you about one of them in a moment. It's actually a breast cancer patient. She came in, she had a left-sided breast cancer, and she had lymph nodes under her arm on the left side. And we decided she was going to get chemotherapy before she got surgery. So we treated her left breast. And after 6 cycles of 12, they got a scan and her breast tumor went away. Okay, great. So how did the ones under her arm do? Didn't go away. We then switched treatment for the other 6 cycles of chemo to under her arm, went away. Double mastectomy, took out the lymph nodes, couldn't find cancer anywhere. That's pretty good evidence, because she was her own control, that we probably helped that patient. So I would say, there's a percentage of people that walk through our door that we don't help, but that's because the underlying therapy doesn't work. Now, fortunately with radiation has a pretty good track record. Now, it's local therapy, doesn't treat your whole body, but it's pretty darn good at what it's supposed to do in prostate cancer. So that's one advantage we have when we're dealing with patients with prostate cancer. Cervical cancer, same kind of an increase. 57% complete response rate to an 83%. I'm not going in depth in the study, obviously. We're just trying to get through the talk and such. Colon and rectal, 48% up to 72%. Melanoma, 35% to 62%. Again, just trying to do apples to apples. And head and neck cancer, you remember that was the one where they had that increased overall survival. We tend to do really, really well with head and neck cancer, okay? And so I'm just going to give you one little visual to walk away with, okay? This was a 46-year-old woman. She was actually treated before my time in hyperthermia, but she was treated with, she had stage 4 non-small cell lung cancer. There was progression to the submandibular gland, metastasis, despite having had very specific targeted therapy. And look at that tumor size, okay? So she was treated with 33 sessions of IMRT, fairly large dose. She was treated with the Sonotherm 1000. And that's where that tumor was. Okay. Now, again, as you know, when you use chemotherapy regimens, you'll often combine 2, 3, 4 agents. Well, you can't separate them. So how much did the radiation do? How much did the hyperthermia do? I don't know. All I know is that lady got a very, very good result. Okay. So again, that's kind of the end of the presentation. I'll play the presentation from the start just to kind of give us a little background. And I think we are right about, 35 minutes into the talk. So I've gone right in my window, and I will certainly stop there, except to say that I'd like to talk for a moment about adverse effects. Okay. We have no known adverse effects on normal tissue. Regular cells, and we treat spinal cord all day long, the spinal canal, and we don't have people twitching or anything like that. Seems to be pretty robust against that level. Remember, we're not burning anything, we're just heating it to change the physiology. We don't heat enough to get a 3rd-degree burn. We certainly have seen blisters, they're pretty unusual. We've seen heat rash, pretty unusual. Reddening of the skin, very common. there are one-off things that happen. If you treat right over the stomach, sometimes you get a bit of nausea. Bone tends to be a heat sink. Now, when you're treating the prostate, there's really no bone in the way. Okay, so that's a good thing. But when you're treating a liver, for example, as we often do, because a lot of tumors metastasize to the liver, you got ribs in the way. So sometimes, even though liver is soft, easy to treat, you got to kind of treat between the ribs. Well, you're also heating the ribs. So sometimes you can get some bone pain and things of that nature. So this is not without any side effects, but it does not seem to increase the side effects of chemotherapy. It does not seem to increase the side effects of radiation therapy. Also doesn't seem to make them better. But that said, if you can get that edge, right? I mean, this is like for your life. You're going here, right? And if you've got the time, and again, most insurances cover it, not all, and not in all situations, but most do, and we're in network with many. It's a great thing to consider doing. So that's where I'll end. And I thank you so much for your attention, and I look forward to your questions.
Thank you, Dr. Pinzone. I've been in this organization about 6 years. I've never seen anything like this at all. This is fascinating. Thank you so much for presenting, and we've got a couple of questions for you. One from Larry. Can hypothermia be used to treat prostate cancer in the sacrum S1 vertebrae?
We treat sacrum and the vertebrae all the time. So it absolutely can be. And most of the time these days, it's a short course of radiation that's being used to target those bone lesions, often 5 treatments. Depends on the institution, depends on what the goal of the therapy is. And we can certainly be added to that therapy in those areas. Do it all the time.
Outstanding. Larry, did we answer your question? You can unmute if we didn't. Okay. Ira's one of our education people here.
Okay, I'm back.
Hi, Larry.
Hello. My S1 sacrum has been treated with proton radiation previously, and it is now at maximum dose. So I can't have any more radiation, and I'm looking for non-radiation therapies. And I'm thinking that your approach with hyperthermia might be a good, what would you call it, secondary treatment?
Yeah,
But
I'm sorry. Go ahead, sir.
No, that's all right. Thank you very much.
Yeah, no. So this comes up quite a lot. The notion of, can you ever use hyperthermia alone? And the answer is, the FDA does not tell me how to practice. By and large, I try my best to stick to the way, and the vast majority of our patients, I'm not saying I've never used hyperthermia alone, but the vast majority of our patients will be having concurrent chemotherapy and concurrent radiation therapy while they're getting hyperthermia. That's how it's meant to be used. That's how I use it. Having said that, when there are situations in which there are no options, then I certainly do consider, for example, certain situations and say, you know what, as long as we're on the same page, I would be willing to try hyperthermia as long as our goals are clear. So for example, if you said to me, I've got pain, nothing is getting rid of it. Would you try that? I probably would, So again, I want to be real careful treading here because it's a very slippery slope. And, we have a lot. I'll give you an example of a place where I would not use it. For example, we had a lady call me up, and we have this, and various people, men and women, call me up with thyroid cancer, and they want to use this instead of surgery. I say, absolutely not. Absolutely not. Thyroid cancer is very, very curable. It's your body. You do not have to have the surgery, but I do not want to play into the thinking that we're using that instead of something that might cure you. That I don't do. But if you have stage 4 cancer and you're in pain and we might be able to help you, and we're on the same page and we're in a reasonable realm of medical care, I would say, sure, I would consider doing that. So I know that's a long-winded answer, but it's a nuanced topic, and I wanted to answer that for everybody who might be thinking of, whether it be themselves or a family member with a different tumor, hey, can this ever be used alone? I'm not saying never, but I'm not going to use it instead of something else. That would be inappropriate.
Well, thank you. I'm going to go to Ira here in a minute. Oh, hi, doctor. Did you want to make a comment?
Yeah, I did. This is fascinating to me also. I must say, this is new. I haven't been familiar with this, but the perineum, where you're mentioning that you use it, is one of the most sensitive areas of the male body. Do you have any issues with skin changes or any issues of people's going, oops, or I know they probably, after they get done, they're hot to trot, but that's a whole different area.
Yeah, that's we really seem not to. It's surprisingly well tolerated. So here's the thing. Our nurses are amazing, okay? And you get a call button. So they're in and out of the room pretty constantly, but let's say they're out of the room. And, I'll give you the analogy of you're holding your arm under hot water and you're reflexively thinking to yourself, my gosh, I better pull my arm away from the water. Ring your call bell. We'll lower the temperature. I mean, this is not a hero's journey here. But it's surprising, even in the head and neck region, where, radiation will just, as you know, many of those folks will have to have feeding tubes. I mean, it's very sensitive in the mouth, mucosa and such, and in the rectum, for example, and in the perineum, as you point out. Very sensitive areas, very well tolerated. It's surprising, but it's pretty well tolerated. Well, part of it too, so I didn't show you what we would capture as a treatment, but it can graph the temperature. So the machine doesn't turn on and boom, you're at 109, the tissue. It gradually gets you up there to after about 10 minutes or so. So that's part of it, is you're getting a little used to it. And by the way, these are multiple treatments. Each treatment takes 1 hour stem to stern. So you're typically at temperature for about 45 minutes or so. And it takes a little bit of time to get to that temperature. So that warming effect, again, some people will have some discomfort, and some people that will be limiting, but that's unusual. The most common thing is people will sleep or work on their phone or listen to music while they're getting this. So it's surprisingly well tolerated, but a very good question.
Yeah, you're dealing with an older age group, and attention span isn't that good. If they get any discomfort that they want to wiggle around, or
it seems to be okay. We have many, many, many men with prostate cancer that we've treated. Doesn't seem to be a problem. Yeah.
we are recommending everyone get transperineal biopsies, but as soon as people see that needle in that particular area, they get very squirmy. But if this doesn't cause any skin changes, that's probably not an issue.
No, it generally doesn't. I'm not going to say never, but it generally doesn't. Now, realize that we do use this with radiation, which does cause skin changes, but we tend not to make those any better or worse. Certainly not any worse, that's for sure.
Fascinating. Thank you very much. A great
Sure. My pleasure.
Ira, we're going to circle back to you. You wanted to know, what are the side effects of hyperthermia? Emphasize total prostate versus focal. What clinical trials are being considered? And that's a good question. Is this in the trial phase? Is this starting to approach standard of care in comparison to other treatment types? And in parenthesis, I'm confused. How does the treatment compare with TULSA that uses MRI? Those are all excellent questions.
Yeah. So let me try to put it in context for everybody. So we'll talk about the side effects. I think I've already talked about. Really not too much in the way of side effects. The reason why hyperthermia never really caught on is that when the machines were first constructed, the business model was to sell them to radiation oncologists. Now, radiation oncologists are like super bright people, and they had really the right idea in terms of wanting to look and see what the exact temperature is. They would put a temperature probe through the skin. Now, that actually probably did hurt, let's be clear. And so, but radiation oncologists are not the quarterback, right? So they can't really do anything. They can't quite order a therapy without talking to the oncologist. And the oncologist really didn't know what this was and kind of got lost in the sauce. And in the meanwhile, the NCCN guidelines came out, and it costs a lot of money to get into those guidelines often, depending on what therapy you are and what the goal is. And so it made it into the guidelines briefly for breast cancer, but it never really worked itself into what's considered mainstream, even though we are mainstream. So yes, there are 4 clinical trials going on in prostate cancer. And it's funny that you should ask that, because I almost included those trials, just the names of them, in the talk. And then I figured, I would have included that more about them if they were not also single-arm trials. So because we are appropriate, because we're FDA approved, we're not in the trial stage. It doesn't mean that we have data in every tumor type. So again, I'm going to go back and say at least we have data in prostate cancer. It's not the strongest data, but there's data. And the bottom line is that I can't undo your radiation. So if you're going to get radiation for curative intent, okay, and or you've got a recurrence and you're going to get radiation, you got to make it's got to either fish or cut bait, right? You got to decide. If you use hyperthermia along with it, then you're going to be in lockstep every time. Right before you get that radiation, you're going to get hyperthermia. You're going to open up those blood vessels. You're going to put that oxygen where it needs to be to go damage that DNA. That's the goal. So we're past the trial stage. Having said that, it would be understandable if people would say to themselves, gee, I wish there were better data in prostate cancer. I certainly wish there were, but there is what there is. And we have a pretty good track record of being able to treat people with various tumors with selected stories from our own experience, which, like the one I told you about, the one with breast cancer, shows there are certain people that we help an awful lot. But that's true of everything, right? I mean, think about what it is, in prostate cancer or in breast cancer. There's no guarantees. There's just no guarantees. Would you excuse me for 1 second? I'm just going to step away. I'll be right back.
Sure. I'll step in here for a minute. Brian, who is our Chief Technical Officer and wizard at large, will be posting this video likely in about a week or so, at what point it will be on our YouTube channel and accessible for you and yours. My hope is that as you watch this, if you know somebody with breast cancer or another kind of tumor, share it, because this is a generalized adjunctive treatment. It's not specific to prostate cancer the way, let's say, Tulsa Pro is. Okay, welcome back. You were about to say something, Doctor? Or would you like me to go to another question?
No, please feel free to go to another question.
Okay, Francis of Oregon. Focal therapies often try to be short in duration. How much thermal energy is necessary to facilitate such focal therapies, or is that not part of the standard approach? This doesn't sound like focal at all. This sounds like something very different.
No, in fact, if I could, so we're fabricating new machines. We've got a physicist who is consulting on the parameters to be able to create machines that meet these specifications, but are up to date in terms of their inner workings and technology. So she asked me, she said, what's your wish list? And I said, I'd love a bigger crystal, because there's no downside to treating cancer, and I'll explain why in a second, to treating a larger area of cancer for many areas. Prostate's different. We have a smaller head, obviously, for the perineum. But the point is, if I can treat a larger area, I would. And she said, well, you've got the largest crystal I make. And I said, okay, well, then we'll take it. We'll keep it. But the large crystal is about 6 to 8 inches by 6 to 8 inches, something in that range. It's not that it varies so much as the water bolus is a little bit, it has to make contact to a certain area. The smaller one's about 4 inches by 4 inches. Again, excuse me real quick. I just have to let my dog in from outside.
Okay.
I apologize.
That's all right. I'll be here in the meantime. So by all means, share this with your loved ones, people who are going through breast cancer treatment, other kinds of cancer treatments now, because this sounds to me to be, and I'm not a doctor, but it sure sounds to me like to be a low risk, low impact adjunctive treatment that can do a lot of good without adding more radiation and more chemicals.
Yeah, and I'm going to dovetail off what you just said, because I'm going to double down on breast cancer as an example. So one of the reasons why women will need radiation therapy when they have a lumpectomy, and often, not always, but often will not need radiation when they have a mastectomy, is a mastectomy. Now, the knife's not going to get every last breast cell, but it's going to get almost all of them in a mastectomy, okay? In a lumpectomy, the first place, and again, there's no rules of the road here, but generally the first place that a cancer spreads in a breast, and this is not true of all cancers, is in the other areas of the breast. So the radiation's got to treat that. So when we have a woman with a lumpectomy, I want to be able to treat as much of that breast as I can to be able to cover as much area, because I know where's the most common site of recurrence. It's on the scar line. It's stuff that they just missed and they couldn't see it. It's microscopic. Then, not so much in exact sequence, but sort of conceptually, then it goes to the lymph node. Then it goes to the liver and the other organs and things like that. And so it's not dissimilar with prostate cancer, right? You might have 2 or 3 foci within the prostate. I want to treat the whole darn thing. If you're going the route of curative intent radiation, or you've got a recurrence and you're getting radiation, the more I can treat, the better. If I can treat those lymph nodes that surround the area, and I typically can, I can't treat I can only treat so much because the area is small where we're treating. But I want to treat as much as I can. So there's really no downside. This is not to be confused with HIFU, okay? That's high intensity focal ultrasound, and that disrupts tissue. That's different. That's a tremendous amount of energy being focally put in to disrupt tissue as a surgical type treatment. I don't know too much about it, so I don't want to over speak on it, but it's fundamentally different than what we're doing. We don't use I don't want to say we don't use a tremendous amount of energy, but it's not energy intensive, it's temperature dependent.
Thank you. Bob has a similar question. How can this be used in biochemical recurrence after prostatectomy? With a question mark, can we use it with spot treatment with spot radiation? I think what Bob's thinking of is something like an MRI-guided SBRT type of a deal.
Yes. So the answer is absolutely. So when we use it in biochemical recurrence, the biochemical recurrence is typically thought to be in the prostate bed. So when you're in the prostate bed, you're treating the same area. And it's a presumptive recurrence, right? So as an example, let's say, there's an analogous test where you're looking at tumor DNA that's floating in the blood. Now, that in theory could be coming from anywhere, and that's in many different tumor types that I'm talking about. So, can anybody ever say that the biochemical recurrence is definitely in the prostate bed? They can't. Could it be in a bone? Sure. But if you can't see it, then you're going to just presume that, much like breast cancer, the most common area of recurrence is where it started. So that's where you're going to treat by default. So the answer is yes, we can absolutely treat that as long as the presumptive area that's getting the radiation on a biochemical recurrence is the prostate bed.
Suppose a PSMA PET CT actually finds a defined spot somewhere, and that spot's going to be treated as opposed to the whole bed. Could this be useful?
Sure. Now, if the spot is within, okay, so let me back up. The abdomen and the pelvis are one cavity, okay? If you drew an imaginary line at the hips, below it's the pelvis, above it's the abdomen. Why it's separated? I think everything converges down in the pelvis. So in some ways that makes it easier to treat, and in some ways that makes it harder to treat. So as long as I can physically determine that I can get the Sonotherm 1000 to point towards the spot, I can treat it. Whether that spot's in the prostate bed, whether it's in a lymph node, or whether it's in a bone, I can treat anything except central lung, and I can't treat inside the skull because the skull, the cranium will absorb the heat before it gets to the brain. Anywhere else I can treat as long as I can access it. There are some places, for example, somebody gets a colon cancer and it's up in a certain part of the abdomen. Or its lymph nodes are in the really way in the back near the kidney. I often can't localize them. It's difficult to treat those. But if the PSMA shows me where the spot is and I can get my probe to point at it, it's treatable. Think of it that way.
Okay. Thank you.
Yeah, similar question from Francis. Suppose I'm going to get 5 days of SBRT at UCLA. How would that be integrated with your treatment at your facility, or is that asking too much of thermal treatment? It doesn't sound like it's asking too much at all. I mean, even if I'm being treated by an outside facility, I could go to you for adjunct at
Do it
home.
all the time. Well,
Yeah.
let me just say, we don't give chemo and we don't do radiation. So every facility is an outside facility. It's a very, very straightforward formula for us to use on each of those 5 days. Now, there have not been any studies with chemo or with radiation about whether you ought to do hyperthermia before or after. I will tell you that I am very, very open with patients, okay? And I say to them, from a common sense perspective, if you're getting chemo and you can come right after the chemo's put in, it probably makes sense to get treated right after. Now, the vessels do stay open for a period of time even after the tissue cools, but we're talking hours, maybe a day or something like that. So if you had a choice of getting 0 treatments or getting treated before the chemo, get treated before the chemo. Radiation is the opposite. If I can open up the blood vessels right before you go get that radiation, I would prefer to do it that way. Having said that, many of those trials that I showed you were done right after the radiation. So it hasn't really been studied. I wouldn't knock yourself out. I wouldn't not get the treatment because it couldn't be done in the proper sequence. But if you're within 2 to 4 hours of the chemo or of the radiation, you're absolutely just fine. And the chemo, by the way, we treat many times during that chemo treatment. We're talking about radiation here because it's a little bit easier to conceptualize. Gosh, I want to get that oxygen every time that radiation beam is pointed where it's supposed to go. That makes sense. Chemo, chemo does stuff to cells. Cells have to be in a certain part of the cell cycle, and that chemo stays in your body for days, often longer. So we're treating patients many, 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 many days throughout their chemo cycle. Even though they're getting chemo, they're not getting chemo every day, like you're getting radiation every day. So to get back to your question, you're getting 5 treatments at UCLA. So you're coming to us 5 times.
Outstanding. One more question here from Ira again. Do you have any literature that you can share? Ira, what kind of literature are you looking for? Are you looking for flyers? Are you looking for clinical data? I think he's here. There you
Yes.
go.
Clinical data, whatever information you have that would be applicable. Clinical
Right.
data
So we
or whatever.
So we have the trials cited on our website for the different cancers. Again, we don't have data for every cancer. We don't have randomized data for every cancer. So whatever we are able to cite, we cite on our website. And it's not the end all and be all. There's studies that have been done since. But that's the best place to go is hcioncology.com. The place
Could you repeat that, please?
Certainly. It's HCI Oncology, so HCIONCOLOGY.com.
Does anyone else have any questions for the doctor? Want to open your microphones and ask them in person? You're more than welcome.
So if someone has failed treatment for, say, for radiation or whatnot, this could be used afterwards. Is that correct?
So I'm going to get back to the question that was asked regarding treatment of the sacrum after, I think it was Larry that asked the question about treatment of the sacrum. So that's an example of something where if there's pain and we have a treatment goal, we could potentially use it after the underlying therapy. But that's not the rule. That's the exception. We would only be using this concurrently when you're getting the actual radiation, when you're under chemotherapy treatment. We want to use it with those therapies because we make those therapies work better. That's the main way. Now, have we been shown to have any cell killing at all with just the heat? Yes, we have, but not nearly what radiation uses, not nearly what chemotherapy does. So by and large, we do not use hyperthermia alone or after, for example. That's exactly why I made the statement. You've got to either fish or cut bait. You got to figure out what you're doing before you get the radiation, because I can't undo the radiation. I can't help the radiation once it's done. It won't, it's not going to really do any good for you. I mean, it might do a little, but it's not the way it's designed to be used.
Where else is this available besides your facility?
We have the only technology that uses ultrasound. My understanding is that places like Cleveland Clinic, Duke, University of Maryland, Jefferson, MD Anderson have the microwave-based technology. I don't know that for sure. UCSF has some technology that they can use that's FDA approved. That's not ours. But ours is proprietary to us in terms of the technology. But the field of hyperthermia being with microarrays being FDA approved, they are at other institutions. I would say by volume, we probably do far and away the most treatments that of any institution's best guess. I don't exactly know what they do, but I'm told by people we do quite a lot compared to other institutions.
Outstanding.
Thank you.
Any other questions, gentlemen? Well, Dr. Pinzone, I'm looking forward to having you back, and most especially if you have new technology, new applications, new data, we'd love to have you back.
Sure.
By all means, share this. We have another presentation with someone who is an outstanding presenter, and you've likely seen his videos. It's Jeremy Calais, MD, PhD, UCLA, a researcher, a professor, and a care provider with UCLA Medical Center. And we're going to once again talk about theranostics, which we haven't done in a little while. But we're going to pull a little surprise on you, and this is not an April Fool's joke. Dr. Calais will be here 5 p.m. Pacific time on this Zoom link, April 1st, Tuesday, April 1st. So mark that on your calendars. You want to be here Tuesday, April 1st, 5 p.m. Pacific for Dr. Calais and theranostics. In the meantime, we look forward to seeing you at support group meetings. If you're watching at home on YouTube, check us out at www.prostateforum, as one word, .org. That's prostateforum.org. Check out our website. There's many, many videos like the ones you're watching tonight. And you can contact us through the website. And there's Dr. Metzger's outstanding newsletters archived on the website. In the meantime, if there's no other questions, have yourself a great night.
Thank you very much.
No, thank you.
Good.